Started? What? Mustang sound.
She said Yo no soy marinero, yo no soy marinero, soy capitán, soy capitán, soy capitán. Bamba, 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 bamba. All right, thank you. That was Anthony.
No, that wasn't.
About you.
Playing the camera, huh?
When it was done, fingers stopped shaking. I began to cry. I began to stop. We began to wrestle. I was on the top. I want to thank you for that man. Be myself again. Now I want to thank you for that man. Be myself again. Just break your
Say bathe from the top to the bottom to someone who didn't know where to start. Makes sense, right? Just start with your hair and go down. But what if that person always did something else, you might, and sometimes you might not find out till like halfway through their stay that they always wash their feet first, or something totally different than what you were doing, But I think the point is that it would be good if you find out strategies that work to communicate them, to the therapist or the therapist to the nurse, that like this is how he does best in the shower.
Mostly patients are very good at washing it all in the front. How about the missing their backs? Because obviously patients
the
cannot.
back is not included.
The back is not included?
So the hair and the back. So, if you ever, you're in a hurry, and those are the things that don't count anyway, that's what you could do for the patient, and if you want to give them a chance to see what they can really do on their own, the other things are what's included in the number. We want people to be able to wash their hair and stuff too, but those are the things that you don't even have to think about, because it's kind of considered, I guess they consider what really matters is just to wash the main parts.
So if we have a
whether or
patient-
not people wash their hair, it's not.
So if we have a patient who is very good at bathing but missing their back, we score them high score.
Yeah.
We give them high score, regardless the back
You can be
is
independent and not wash your back
Really?
according to these
according to
numbers.
this thing.
It's hard.
Yeah.
You can
That
not
doesn't
wash
mean
your
you
back.
don't work on washing their back.
Okay.
Yeah.
Included when you
Okay.
do not washing your back.
Right?
And
Because
some
the bottom is
people,
also the part of the
I can't
back.
wash my back.
That's something to
So we just neglect
Gotta
that.
work
Okay. Don't make any discoloration of your undergarment. Okay.
and the more people you shower, you notice how some people, they don't wash their back. They let water run down in. That's fine for them.
I
And so,
see.
and some people really scrub between each of their toes, and some people just wash over them.
Okay.
You're gonna see differences between how thorough people are. But washing the back and the hair, that's the important thing to remember, that those don't count. So I think that's where we think of a shower, we think of washing your hair, but it's not.
I want to add something that when she's mentioned about evaluating the patient and letting them do it on their own, that's pretty much like the first time. But then after that, our job really is to train them
Mm-hmm.
to do it on their own.
Correct.
So you're not just going to, because you bathe them every day, you're not just going to back off every day and say, okay, do what you can. That's just for evaluation purposes, because that's not the training part. So go ahead and train them and give them cues.
Okay.
But remember how many cues you're giving, because that will enter into how much help you're giving or how much physical thing you're giving. But don't feel like you just have to evaluate just to come up with a number, because you evaluate every day and every shift.
True.
And otherwise you would just be standing there doing nothing,
Yeah.
because you're worried about evaluating. Don't worry about that piece.
And you
of it.
still
Just
want to think,
get the
how can
sense.
after you establish, after you establish, okay, this is the order they're going to use, or they're not going to do this on their own, you have to think, the goal is to get them to not need me,
Okay.
to not need you, to be able to go home and shower by themselves. So that's the point Terry was making.
There's one area that we encounter difficulties working with patients in shower. Some patients doesn't want to be watched. Now, that's one thing too, that I don't know how equipped the patient's performing bathing skills in his room and how safe he is. So sometimes when the therapist comes and says, because patient has to have a bill of rights, I need my privacy. But if the therapist comes in and says, because some therapists couldn't even get in there because male patients prefer to be alone and he doesn't want to be watched.
How do you usually handle that? What do you say when someone says?
Well, what happened is we discuss with the assistant head nurse and then make arrangements as to what patient makes me feel comfortable. If the male patients prefer male staff, we go for that. If the females go to females, then those things. Because of cultural issues, a lot of people
What
who
would
are...
you say though, if you're bathing a patient or putting them in the shower and say, I prefer to be by myself? What would you say right then and there? What do you say?
No, we can't do this because I'm not so sure. So, you know what? We
Yeah, I
give
just want to
him...
know what you say. What
Yeah, I
you
say,
in that
why don't you go
situation?
for sponge bath? Let's go for sponge bath because I'm not so sure about the safety stuff inside the shower room because the shower room is slippery. There's a highly chance that you can fall.
But I think as a professional, you could say, the first time I need to watch you. If you can demonstrate that you can do this by yourself, then, we can talk about that after. But I don't think you have to totally avoid it because sooner or later they need to take a shower. But, and so that brings up, so if they sponge bathe, what's that? Is that okay? Do you rate that? Is it not counted as bathing? So like when you're giving someone a bed bath, do you give them a number, or is it not considered bathing?
What a question again?
Sponge
It's
bath.
considered bathing.
Yeah, we can do
And
that.
then you need bathing.
So it doesn't matter if it's a tub, shower, sponge bath, you still use the same numbers, right? So if you,
The gym has a shower and has bathing, so and even a shower, you evaluate with a shower if they give you
that's
a
just
bath.
on transfers that it's different. But bathing is, in bathing, it doesn't matter if it's a sponge bath or a shower, it's all rated in the same column, so. So since I know that frequently, you know, and sometimes it's time and you're doing a sponge bath, but trying to get them to still be able to participate in that so they can carry over to washing themselves and into, you know, the shower. Dressing is the next thing. So there's upper body dressing and lower body dressing. What if a patient wears a gown? Does that count?
Hospital gown.
Yeah.
Yeah, because that part of dressing, right?
At the top.
Actually, on the FIM, they need to wear clothing that's appropriate to wear in public. So hospital gowns
So it's
are
not
not,
included.
like says specifically, for the subject who wears only a hospital gown, they should be coded as 0. The activity does not occur. So it does say for the purposes of an assessment, you might be able to use putting on and taking off scrubs, because that's a little more similar to shirt and pants than, but the FIM really wants people to wear real clothes and do real dressing
Yeah, when they go home,
to-
they're not gonna be
to give
wearing-
them numbers.
You see, at an PM shift, we have some kind of standard routine that when patients in the street clothes and they're going to back to bed, they're treating our gowns and our pajama as like their home pajamas. You see, same thing when they go home. They take off the street clothes and then their pajamas. Our hospital gowns or hospital outfits here consider them as their pajamas when they go to bed.
Yeah. But
Now,
just
how do you
the
get? How
FIM
do you,
doesn't count those as clothes for
Really?
dressing. So, but what they would be doing is taking off their
Off
regular clothes. So you could document on the numbers that they do for that. Because you might have someone who could totally take off a shirt, but then when they get to the gown, they're like really confused. They can't tie the things, or they can't, you know, and who cares? They don't need to wear gowns at home. So what, you know, they're not going to need someone to put a gown on them at home because they're not going to have a gown. So we're only worried about regular clothes. So, and then if patients choose to wear, you know, bras, that's part of dressing, upper body dressing. If they don't, you know. So for like, when I think of someone putting a shirt on, I kind of think of 4 parts. Like they got to get one arm in, the other arm, they got to do it over their head, and they have to pull it down. And how much you need to help with those parts. You know, a lot of times with a shirt, there is, like, they get to a point where all they need, maybe you put the one arm in, and they do the rest. Then that is how much assistance. There's 4 parts, and they do one of those. Yeah, 25. So min assist. So, I mean, you know, but sometimes maybe you help them with half of the one arm and part of, you know, and you kind of have to, in your mind, be thinking in parts so that you can tell how much am I really helping them with. You know, but if you look at a shirt as 4 parts, as this is to look at a bra as 3 parts, as the little hints, as putting one arm in, the other arm in, and hooking the bra.
this dressing technique, is it only applies in patients in a wheelchair or it applies also in bed?
Dressing, they can dress wherever they have to dress.
Wherever the is, if it's in the bed for them to practice
Yeah.
the dressing technique versus on the sitting in the chair, because some patients are more competent in the chair versus in the bed, or some in the bed. You know, have the difficulties because some of them they use their bed mobility by turning and bringing down the shirt. Same thing when they're putting their pants, they lift the buttocks. But
Or
in
there
the
might be
chair,
someone who can't weight bear on their legs, and so they
Uh-huh.
have to put pants on in bed, and that would just make them a 6 if they can do it, you know, because it's not, it takes a little more time, it's a different technique, they can't just do it anywhere, you know, if they need to dress in bed or maybe use adaptive devices,
Uh-huh.
they're a 6. But it doesn't really matter, I mean, besides that, it doesn't really matter where they dress.
doesn't matter.
But obviously, you know, for some people, it would be easier to sit up to put a shirt on than to lay in bed. And so they might score a lot better if they're sitting up,
It doesn't
you
matter.
know. But so it kind of matters just for that
So you can
purpose.
also look at what are they gonna be doing at home as their discharge situation. For a spinal cord patient, they probably are gonna be dressing in bed at home too. For a patient on two-center, they're typically gonna be sitting at the edge of their bed or in a chair. And so you want to kind of use that method that you think you're gonna use at home. So that's what you're training for. You're training for them to be independent in the method that they're gonna use when they get home.
Are we also evaluated when they put the bra on? I thought it was only the shirt and the pants.
No, if there's someone who doesn't want to wear a bra, then like you don't rate it. But if they choose to wear a bra, it's part of upper body dressing.
That's hard.
So yeah. Don't make
Or
them
get the
wear a bra.
Get the ones that hurt them
Or
first.
a strategy for a bra is just, obviously some patients have sports bras, or to hook it first so that then they can put it over their head. But it's still hard to get it all straightened out, and it's, it definitely brings the score down, that's for sure, on patients that need assistance. So you have to, if they, basically it's kind of like if they choose to wear it, it's part of, what they'll wear at home, and so we need to rate that.
Lower body dressing, is that including also the shoes?
Yeah.
Okay. You see how competent they tie in the shoelace? Huh?
If they can tie in, or
If you have to tie them after they have put the, is that a minimum assist because you're touching the patient, you're doing it? What is it?
If maybe all you do is just barely touch them, tie their shoes, or zip their zipper, you're still touching them, so it has to be min assist. If there's a button they can't get, they're min assist. But but if they have slip-on shoes or, then maybe they're a 6. If they need, Velcro or something to help them be able to do it like that, then they're a 6. Is that? So lower body dressing is from the waist down, anything. If they wear an AFO, that's part of lower body dressing.
AFO is part of lower dressing.
But the difference is if you put on the AFO for them, that is just considered, that's just considered setup.
And TLSO is also part of the upper body dressing? If ALO is part, then the TLSO is also part of the upper body dressing. So patient has to learn to be independent how to put the TLSO by themselves.
Well, patients can't always put the TLS on by themselves because of the precautions.
But
Because they cannot turn, they cannot,
So normally what we'll do at our conferences to show that the patient got better even though they're not doing the brace or they're not doing the AFO, we'll put a little sidebar and explain, why they need that much assistance, but really they're doing better once the TLSO is put on or something to kind of document progress for our purposes.
And the thing that helps out in that, like Deb said, it makes you, if you have to put on the AFO or the TLSO, they'll still only be at setup. So it won't,
It's
won't
not
bring it down
considered
to
like
one, just because
Max
of that
assist
piece.
because you have to totally,
Right. So it gives
put
them
on
credit for
Give them
that piece, and so it is hard, and it may not be expected that they wear it at home, but it is part of their restaurant routine.
It's part of the setup. Before getting up and getting dressed, they need to
Why
have this
is it
set
set
up.
up? Why is it set up? You're touching the patient. How
Yeah.
come it's not a minimal assist?
Because they don't want to penalize the patient for someone who has to wear a brace, or for someone who doesn't have to wear a brace, so they give that a little break by just saying, you're setting them up.
But neck collar is okay. They can do it for themselves by lying in bed before they get up. Like
A lot of
wearing
the neck
aspen
co-
collar
A lot
or
of the neck collars never come off, so
Yeah.
it's not as much of a, like they have to put it on and off.
If the item is necessary to get up, like a TLSO or a neck brace, they can't get up in order to get dressed, then it's considered part of dressing.
It's part of setup, yeah.
putting the gloves is also for them to learn to.
Well,
Yeah, like isotoner gloves.
No.
no,
No,
that's
do-
just a
not.
positioning, like whatever,
They're not.
kind of like a splint. It's
What
not,
about
unless,
Dead hose, yeah.
whether it's
Yes,
tennis. You guys know?
Dead hose, yeah.
5. That's just considered setup, because it's like something they need. They don't expect people to have to get those on. So it's just like what they need prior to getting up, but they
We
don't
give them
count that
credit?
as part of dressing.
Oh, part
So
of
it's
the
just a 5.
fine.
Same as a TLSO or a,
Test, even though you put the test on, then you go.
That's fine.
I think the people who wrote this knew that people would never be able to get TEDs on by themselves. You know, and some people, like with cardiac problems or things, they're not supposed to put them on themselves, and so they kind of consider it part of setup. So, anyway, so when you are, that makes a big difference for you guys because you put them on a lot.
That's true. It's very
And
hard.
it could really, it would change your number from my number a lot if you were grading how much assistance they needed to put TEDs on, and I wasn't. So,
I'm not sure, Marianne, because one of the questions
And
is.
tubic clips too?
yeah, they
Is it
specifically,
set up too?
yeah, they,
Everything's
They
set
were
up?
including the
Fine.
test.
Fine.
let's see. There's somewhere I even read it specifically in here. I'll have to find it for you guys, but maybe it's in the hint page. Yeah, anti-embolic stockings are considered anorthosis. Application of stockings by a helper is rated level 5. So,
Set up.
okay, moving on to toileting. You guys know what's considered in part of toileting?
What is it? It's called-
What are components?
For this purpose,
Is it when he
And
voluntarily goes to the bathroom?
Yeah, exactly. That's important because it's not, you don't rate toileting when it's like an incontinent episode. That's covered under the bowel and bladder management part that you guys do, the level of assistance and continency. That's in there. So toileting is really just
Going to the.
for a continent episode. So it's cleaning yourself, adjusting your clothing before and after, using a toilet, commode, bedpan, or urinal, actually. So in all the, whenever it's continent, when they're continent and they're using those things, even if it's a time void and they go and they do this, you know, when it's a continent episode, you're rating toileting.
It's a hand washing. It's a part of the components of the toileting.
Nope, that's grooming.
It's okay. Don't touch me.
Yeah.
not to say you couldn't encourage them to wash your hands
That's
first.
grooming.
That's grooming, that's
You're
not
not
getting
gonna,
out.
you know,
Okay.
Toileting is only pull the pants.
Okay, all right.
Okay, I just wanted to know.
Clean yourself.
Clean yourself.
Yeah.
When they want
I guess
to wash their hands too.
they figure the next person who uses the toilet will flush it.
I always told the patients, wash your hands, right?
This is a washing of upper body. Washing hands.
Yeah, or it's part of grooming too, washing your hands and your
but
face.
it doesn't.
Like, you probably, I mean, you know,
Now for the female patients, and they wearing some special pads, is that a part of the toileting too?
It's a device.
usually,
It's a device.
it's just considered a device.
If they
So
used a
it's
pad,
5.
it would be they'd be a 6 if they could do it themselves.
Yeah, but what if they need help with it?
They need help with it.
It's not included. It's not
Depends upon if they have to
included
touch them or
in the
not, or they just get it out of the drawer and get it to them.
Always happen.
I think it's part of toileting.
Also goes to the toilet.
Really?
Yeah.
Okay. I'll ask Marianne too.
You read the bladder part, because I think it's in the bladder section rather than the toileting. Whether or not they
Mm-hmm. Yeah,
can
it's in
manage,
Diapers.
So I think you're right.
Diapers.
diapers. It'd be like a diaper.
It could be that like diapers.
Just curious.
Yeah. Good
But
question.
if
Women
they can
use them
do
for
it, it's
both
a seven.
urine
Even
and
if
for
they want diapers,
menses.
whether they can do it themselves, then that is 7.
Okay.
Okay, so any other questions? So really kind of 3 parts about toileting. Pulling down the pants, cleaning yourself, pulling them up. And so if on your shift, all they do is, you know, bladder, it might be a lot easier than maybe the PM work. So that's where you'll see the numbers are different. And that's why, like, for us, because sometimes we don't, we're rating toileting and like feedback on, well, you know what, when they have a BN, they really can't clean themselves, or they're needing this much help, or whatever. It's helpful to really get accurate numbers a lot of times.
Or in during the night, they're just sleeping, they feel that they cannot do it, and then we have to do it all of it. And then probably sometimes during the day, they rated as a 4 or as a 5, but during the night, they are not doing anything. So that's what we have to document why.
So,
The difference between one number and another.
But I think we have to make sure that the patient is given ample opportunity to do it, or is it the staff just saying, it's too much work to get the patient up to go to the commode, I'll just do it for them. That's not, you can't grade that, you have to let the patient have the opportunity to do it. And then if they can't do it because they, for whatever reason, then grade it, but just because it seems too inconvenient or they appear too tired, you have to give them an opportunity to do it. Otherwise, they'll always be a one.
Refuse.
That's fine. That's fine, but at least you try. You encourage them to do
I
it.
give you the best
as much as they can.
opportunity when I have time.
yeah,
When I have time, no time.
that's the hard.
Really,
That's-
okay?
Yeah.
That's how it is.
That's the one I do.
But
When
what
I have
happened
time, I give it time the patients to do whatever he wants.
So if you have to have them stand up to get their pants down, is that part of toileting or is it part of the transfer? Yeah,
Trans-
Vicky's right, it's part of toileting,
Part
because
of
they can't
toileting.
really get their pants down if they don't stand up, right? So, I mean, unless you have someone who can really wiggle them off while they're sitting on the toilet, then that's fine. That's their strategy, but most people have to come up a little bit if they need help with that. That's part of, it's kind of like, if you think about doing the transfer, getting them to the toilet, and not doing anything with their pants in the middle of the transfer, then how much can they do? Which is what you're grading, whereas sometimes what we do to save time or whatever is we'll yank the pants down in the middle of the transfer. But really, there might be a patient who needs help with the transfer, but could participate more if you did it in 2 steps and allowed them to come up and then get their pants down and sit back down. And then, so sometimes it's just adding kind of an extra step to do it that way. But, so, toilet transfers, I only have 2 more left, is getting on and off the toilet safely, right? Any? I think most of you guys have a really good sense of, are they doing 50% of that or less? Any kind of questions about?
Well, in our toilet setup in second centers, there is a parallel bars installed. Patients using those adapted device for them to get up, not getting up on themselves without using those parallel bars. You see how you graded that. You see he's very good at using the adapted device, using the parallel bar to get up. But he's very good at his balancing
Well, I
and
think
safe transfer to the chair.
on our toilets in the room, the highest anyone could be is a 6. Because first of all, you're dealing with a raised toilet, which is not a standard, it's a modification. And if they use the bars.
If they use the bars,
So just using that toilet in and of itself, or using a commode, puts someone at a 6.
6.
Unless you take them like in that little room off the day room or one of those bathrooms that has a low toilet, you're not really doing a regular independent toilet transfer. So really for our purposes, for what you're doing in the room, the patient probably only is able to be a 6.
6.
I think, Carla, what you could do is periodically ask the patient not to use the bars, just to see. Because they'll use them if they're there, and maybe they don't really need them, but
That's true.
they're just there.
It's become a habitual for them.
Yes, so just try, say, could you try it without using the bar, so long as you know
That's true.
their status in it.
See, we have a toilet set up close to the day room that there is no bars. But it's so funny, on that toilet, that close to the day room, the toilet is very low. And it's not appropriate for the tall guy. And it's very hard for them to get up.
It's the same
So I have a
toilet
patient
the
on
tall
6
guy used before he was in the hospital.
I have a patient who was then
Yeah.
6'4", and he used the toilet and he had difficulty to get up. Because my toilet is very low versus the toilet in his room. So that's one thing too, and then I said, okay, I need you to pull me up. I need you to pull me up. So,
And
different score on that
Yeah.
toilet setup versus the toilet setup that we have
Yeah.
in his room.
And the other thing about toileting that I think is going to get you different scores is how you set up the wheelchair. And whenever we transfer someone to the bed, we get as close as we can, right? Because we're getting them to the bed, we want to make it easier for them, easier for us. But somehow, sometimes when we do the toilet, because it's crowded in there and it's hard to get around, we have them transfer from straight onto the toilet. And you wouldn't get someone back into bed that way, right? You wouldn't pull up to the bed and have them turn all the way around and get in the bed. So why do we do it in the bathroom when the toilet's harder and when, you know? So I think that's where sometimes too we'll have different scores because maybe one person is taking the time to pull the chair around, get it as close to the toilet as they can, and let the patient do as much as they can on the transfer compared to just wheeling the chair straight in and having to spin them all the way around and sit them on the toilet. So I mean, I think that as you do different transfers, like for toileting and for the tub, is to really think about the setup to give the patient the advantage to be able to help more. Because even if they're doing their own setup, we want them to set it up in the way that's easiest. I mean, we don't want to have big gaps between what we're going to if we're able to get close to them. Of course, in the toilet, you can't get right next to it because of the bars and because of the space, but you can get closer than just wheeling them into the room and spinning them around, you know. So, I mean, I think that would also, because I think part of the goal is that this is to try to, you know, have accurate information when we're rating the FIMS and to have, you know, good communication between each other. So I think the way we set things up, if we all set them up the same, then our numbers will be more likely to be the same.
Yeah, sometimes it's hard to transport the patient to the chair to the toilet because the bathroom is too small, and the chair is big and no
Yeah.
space to.
And especially the recliner chairs are really hard to get
it's
them
hard.
close in there. And maybe for those patients, we're better off just going to commode, you know, I mean, truthfully, because it's not a very safe transfer if you can't get close.
We have some
And
heavy
they're not
set
able to
patients.
get good weight bearing on their legs, and you could be at risk for hurting yourself. So in those situations, if you really can't get the chair close, I mean, we probably shouldn't even be in the bathroom. We should just be on the commode. Because that's what they're going to use at home probably anyway, and, you know, it's not like really setting them back to, I think we're being less therapeutic by trying to get in the bathroom, even though we're using a toilet instead of a commode. But
Yeah,
Some
but
patients really want to use the toilet
sometimes
instead
it's
of
hard
the
to find a commode for the patient to use it.
I don't know, we always have the practical, like,
And the time when the patient asking they want to go to toilet, you cannot wait too long. You have to put her away.
just let me run around 5 minutes and then
See, we have a heavy set patients that it won't fit to his restroom, but he is very competent, the skills, you know, of toileting. And we have a hard time how we're going to grade him because the bathroom is not big enough to accommodate her needs. And we don't have that because our bathrooms here in each rooms are standard size. And it's not fair for that individual to not be able to perform independently his toilet needs, you know, things like that. So, and then you're going to put him in a commode because we have this a super-sized commode. That'll only lower his score. But he is just trained to be using the bathroom when he goes home. So how you be able to work on that and putting in a good score? I know you have skills, I know you're competent, but can we use it as a commode, as a toilet setup?
It's the same.
Same.
If you're on the raised
Can you
toilet
do
or
that
on the
too?
commode, it's exactly the same
Exactly.
score.
Yeah,
Yeah.
you're not decreasing the score at all.
Mm-mm.
If they can
Correct.
do it independently in the bathroom on the raised toilet seat, and they can do it independently in a room with a commode, it's the same.
Same.
Okay.
Yeah,
So
same
you're not,
score.
it's
The
not
only
breaking
score
down.
that's going down is the one for bowel or bladder management because the commode has to be empty. But I think that's fine.
Okay.
Because chances are that patient who you can't get
It's
close
gonna
enough to the
have to be
toilet to
at home
transfer
anyway.
is going to use a commode at home anyway.
But if he's using the commode, he's gonna be a 6, he's not gonna be a 7.
Right.
That's fine.
And
Or if they use the
except in
toilet,
bathroom, in our
either,
bathroom,
because the raised.
The difference between a 6 and a
He does
7
well, yeah.
isn't really a big deal because it doesn't involve
A
needing a
person.
person to help you. You know, if you're a 6 or a 7, you're doing it by yourself. Whether you need extra time or you know, in what FIM is looking at or what we're looking at on their caregivers that they need, it doesn't make a difference.
But they
You
need
know?
a second person on the phone.
So,
Yeah.
on the second center is hardly a 7, and I have seen a
There
lot of
isn't
7s.
any. There isn't any.
Yeah,
It
that's
shouldn't
true.
be. Yeah, no,
Yes. Except I mean, if the patient has, you know, a lot of times the therapist, before they go home, we will, and throughout the stay, we'll take them down to some regular toilets to see how they do when we're determining like what equipment we should order and stuff. So we could know that someone is a 7,
But you can't give them that
But-
score,
but
because you
they're
have to use the
using,
low score
yeah.
for the last 3 days.
so we'd rather have some low toilets, I guess.
Yeah.
And then the last thing is tub and shower transfers. And that's just getting in and out of the tub or shower. And there we just grade whatever one they do more often is what they want. So for, I mean, you guys are always doing showers with people, so that's not tub transfers. Whereas sometimes what we'll do is tub transfers, or if we know that's what they have to do at home, we'll try to do more of those. But
We transfer to the shower bench,
yeah, or chair.
chair.
Or if it's someone who just stands up, you know, they get out of the wheelchair and stand up, then that's the transfer to the shower.
Right.
I mean, our shower doesn't involve like anything you have to step over or do anything, so it's pretty. And if you're just wheeling someone in a wheelchair, they're not really doing a shower transfer.
Do you really do the transfer to the top? Because really, with the top?
We have a tub downstairs in the ADL area. We do that.
But
You still may
inside,
use a bench in there, and some people may go all the way to the bottom of the tub. Is that your question? Depends on what the patient wants to do. There's some patients who really want to take a real bath and get in the bottom of the tub, and we'll work on that. If that's something that's really important to them, and we physically think they can do it. We're not gonna get someone in the bottom of the tub that,
You can't get 'em out.
or something, you know, we just have to
Exactly, how
recommend
is
that.
gonna get out?
No, it's only for those patients who could potentially actually really do it and be safe doing it, because it's very slippery and, you know, it's just
Yeah.
it's an accident waiting to happen.
Has to be reasonable for them.
is the transfer to the bench or to the tub, it's a part of, like, for the safety transfer, like putting the wheelchair brakes, positioning the chairs before patient get up and move to the bench or the tub? Is it a part of the score?
Well,
When you
sort
grade
of.
the patients on the
Whenever
skills?
you do that, that's considered setup.
As to that?
So there are 5. I mean, you could do everything of locking the brakes, setting the chair in the right place. If they couldn't do any of that, but they could do the rest, there are 5.
Because they get set up and kill.
Okay.
And sometimes you don't have to tell them, put the brakes on. So that's killing.
Correct.
But to be independent or modified independent, they need to do all that stuff. Yeah.
How would you grade someone who rolled up in their wheelchair next to the tub, set their brakes, and they got onto a tub bench? What would you grade them?
Be able to do it.
They're able to do it, you're not touching them.
They just need supervision, right?
Mhm.
Maybe
You're
6.
not touching.
That's 6.
That's great. Why 6?
Because
Big
only
legs and
standby
big
supervision, you not physically touch them.
Physically touching, but what are they going to?
So they can
A
do
bench, the bench is the equipment they
Yeah.
need.
The bench is
Yeah,
the
they-
6.
it. So that's
The
a
bench
6.
is the 6.
If they can do it without you there, but they're
Ah.
using a bench or a sliding board or a grab bar, any of that stuff makes them a 6.
They're all 6,
Yeah.
really,
So-
including the sliding board.
Yeah.
Handrails on the stairs are too, make you a 6 if you use it.
Okay.
So some of the stuff we take for granted because it's just there. You know, we know our patients sit on a chair in the shower, but really
And
that's
grabbing
a
the
6
bars
because
is
it's a
6.
device.
I see. Okay.
So
Alright.
I think that's all unless you guys have other.
Thank you very much.
Thank you, Deborah.
Next time you bring coffee and cookies.
I know. I'm sorry. I owe you.
Marianne usually brings that. She didn't say.
She hasn't been
Where is
lately,
Marianne?
not since the budget thing.
Oh. So usually she does it herself.
Thank you.